Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. It's a pleasure to speak on to this August forum, and I think I would like to extend my greetings to all of you who are present on this forum today. And I really thank Dr. Talib Wasim, who invited me to speak on this very thought-provoking topic of improvement in surgical training in Pakistan. I've titled is to be as the pathway to achieve excellence. And okay, before we actually touch this topic, let's see that why improvement in surgical training in Pakistan is necessary. You know that there is a lot of teaching, but very moderate amount of training is available, and even a very little time to practice to gain perfection. So that is where the main problem is, that we are actually not really training people, and we are not giving them enough time to practice so that they become, perfect in that particular session in which they are supposed to get trained. And furthermore, that the surgical practice is transforming quickly due to the advances in medical technology. And this transformation is not matched in the postgraduate training in surgery in Pakistan. And the current postgraduate training in surgical specialties is not fit for the future, in my opinion. And early exposure to laparoscopic, robotic, and artificial intelligence technologies is required for all our surgical trainings. And if we really have to improve surgical training, then a very innovative, evidence-based approach to training has to be adopted. What should be the pathway to achieve this excellence? We need to have a series of initiatives that have to be developed to enhance the experience for surgical trainees, not only to encourage a more focused and a supported method of training, but it should also improve the job satisfaction. When I'm talking to the trainees, I would find plenty of trainees who are not actually satisfied with the jobs. So that is very important, that they should be satisfied with their jobs. And the initiatives have to combine a greater emphasis on time for training provided by the trainers with allocated time for training with multidisciplinary team working and the use of technology enhanced learning with simulation of both technical and non-technical skills. It's important that our budding surgeons, they should learn the surgical skills, the technical skills, but at the same time, they should be quite proficient in their non-technical skills as well. And while talking to my trainees, I really wanted to identify the core problem. Now, the core problem with the trainees that includes the imbalance between the service provision and training, the lack of time for training and lack of flexibility during the training process. And these issues are particularly a problem in the early years of surgical training. The trainees, they have got a very strong opinion wherever they're getting this training. So I, being the director of the National Residency Program, twice every week, I come across the trainees at CPSP regional center, and then online as well. And then they actually, come up with their opinions that how should the surgical training should be improved. And as far as my anecdotal evidence is concerned, with conversation with the core trainees, these core trainees are the trainees which are in the first 2 years of surgical training. And it showed that they are very concerned about the very limited time for training due to the rota configurations. And in addition, access to simple surgical procedures was significantly reduced, again, just because of lack of opportunity to get into the operation theater. It was apparent that there was, it was quite apparent that where there were small groups of trainees within the rota, the opportunity for daytime elective experience was significantly lower in comparison to those where there were more trainees working on a core rota. This is almost contrary to what we believe, that if you have more number of trainees, we would actually not be able to train them. And as per their opinion, the current threats to surgical training are numerous. In particular, trainees have been very concerned about the reduction in the working hours in the operation theatre, especially during the COVID era. And I've come across trainees who have not been into the elective operation theatres for almost a year during this COVID period. And many training surgeons agree that within the current structure, it is not possible to provide higher surgical training within an average working week of 48 hours, what has been actually assigned to us. So let's see that what needs to be done. A series of initiatives have to be taken to improve training opportunities. initially in the core surgical training with the intention that these initiatives are rolled out into higher surgical training as trainees progressed on their training trajectories. So, we start with the basic trainings and then we actually go ahead and try to actually get to the higher surgical training. But this core training has to be strengthened. And the main aim is to improve overall quality of teaching and training, as well as evaluating the time for training and supervision. And this can be done by, providing them with an appropriate balance between service and training, professionalizing their trainers, including curricula that are truly competence-based with a learning environment that embeds and enhances simulation. Now, simulation is very important, and improving the experience of our trainees and ensuring the product at the end of training meets the current and future patient needs. Let's touch the first thing, that is what I would usually actually advocate is a reduced service commitment. Now, this is not a reduced training commitment. This is a reduced service commitment, because actually what we do is that we involve our trainees in jobs which are not really a part of their training. We ask them to actually go ahead and get the investigations done, which is not their job. And we ask them to get the calls attended. We ask them to go and get the medicines for the patients. We ask them to arrange for the theater and the theater equipment. Actually, these are service commitments, and should be done by somebody else, not by the trainees. The trainees should be only focusing towards the training which they are getting. And some work has already been done by the Royal College of Physicians of Glasgow and of London as well, and which clearly demonstrated that larger the number of individuals within a rota resulted in more time available in the working week for the training. And this work demonstrated that when there were at least 10 members of the workforce on a rota, then approximately 60% of the working week would be dedicated to training. You can see from this graph that if there are lesser number of trainees in a rota, then they will get a very little day time for their training. But as the number of the trainees is increased in a rota, you'll see that if there are around 10 trainees in a rota, they will get more time for their training. Roughly in a week's time of 48 hours, now 60% of the time can be dedicated purely towards training. And it is quite clear that the members of the non-medical force would be very valuable in supporting junior surgeons to enable them to attend dedicated training sessions as opposed to providing service activity. As I earlier remarked, that we get our trainees involved in the provision of services, and a lot of time of the trainee is spent just in the provision of services for the patient, but it's not their job. The provision of the services has to be done by people who are responsible for the provision of the services, not by the trainee himself or herself. So it is very important to understand that a lot of their time would be spared if there is a non-medical workforce to help them out. And in my opinion, inclusion of the non-medical force taking part in on-call rota should be taken as a strong consideration. That is, those people who are non-medical workforce, should be a part of that rota of the trainees, so that job, that service job, should be done by these non-medical workforce. So that is my first proposal, that there should be a reduced service commitment for the trainees. I'm not saying that they should not be looking after the patients. It is their job, but there's certain ancillary works which have to be done, and that has to be done by the workforce which is non-medical, and it should not be done by the trainees, like few jobs which I earlier remarked about. And then there's a very important component of professionalizing the trainers. The trainers have to be trained how to deliver the training, and the education of the trainers has to be a routine component of professional development, supported by the training courses. We train instructors in the ATLS, we train instructors in the BLS, we train instructors in the ACLS, pediatric advanced life support and advanced life support in obstetrics. We actually train the trainers. So it is very important that there should be specific training session for the trainers, so that they are able to impart particular training in a particular field. So it is clear that the apprenticeship model of surgical trainees needs modification, with the relationship between trainer and the trainee not only being the practical approach to gaining surgical skills, but also for the trainer to act as a mentor. We should actually teach them not only the practical surgical skills, but the skills how to actually become good surgeons, good communicators, good social people, and actually learn a lot of non-technical skills to become very progressive and achieve success in their life. And in my opinion, long-term attachments to a training host site would be advantageous to the enhancing team working in the context of the modern surgical unit. It is essential that there is an adequate time provided in the trainers' job plans in order that they could develop their approaches and support for the trainees. In particular, this would require regular dedicated time during the working week for one-to-one discussions between trainer and the trainees. And I don't see this happening in most of the surgical training units in Pakistan. Maybe, there is a one-off unit where the trainer would come in a one-to-one interaction for some time with a trainee during a week, where he can listen to the trainee very effectively and try to sort out the problems, and then become a mentor to him and or her and try to sort out things for them so that they could focus more on their training. And the selection of the trainee has to be an absolutely refined process. The process of trainee selection into a surgical training should be enhanced with the aim of selecting those who are most suitable for training, with a dominant role of the supervisor in the selection process. What has been happening in the recent Punjab induction of the trainees is that the trainees are actually sent to a surgical department to get the training without having a good interaction with the supervisor who is supposed to train them. So it is very important that the supervisor should have a very, very dominant role in the selection of these trainings. And traditionally, the training has been time-based, and this has often reflected volume of experience with the required number of index procedures within the context of curricular defined competencies, and the progression of the trainee was based on the competitive selection at key stages. It was entirely dependent upon the trainer that which trainee will progress. This should not happen. Actually, it has to move to a competence-based approach, which is a part of the CPSP new standards for training, and based upon the achievement of defined criteria before moving on to the next level. That is, it's very important to understand that the supervisor should be an integral component of telling the College of Physician Surgeons that this trainee has achieved a certain defined criteria of competence before this trainee is moved to the next level. And there has to be an enhanced role of simulation in the acquisition of both technical and non-technical skills. This has to be implemented. And then talking about the product, it has to be the trainee itself. It has to be recognized that the surgical trainee should be competent in the generality of surgery. The general surgery is the mother of all kinds of surgeries. So in the first 2 years of training, the general surgery should be a very, very integral component, so that the trainee should be able to cope with specific issues, most important being the perioperative care of the surgical patient. They have to be very, very, apt at providing a perioperative care of a surgical patient, because that is what they're supposed to do. The product of training program should be appropriate for outcome needs, which in surgery means that they should be able to deliver independent surgical care for both emergency and elective patients. Now, it's a question for all of the trainers who are sitting here. How many trainees which come out of your training program where you can certify that they are absolutely capable of handling both the emergency and the elective patients once they get their fellowships? So I think that there'll be very few of us who would really boast that this is being done. But majority of the people who are coming out of these training programs, they really are not very, very capable of dealing with all kinds of emergency and all kinds of elective patients. Therefore, the training in the early years has to be broad-based, and in particular in general surgery, this should include the breadth of general surgery together. Acute urology, acute thoracic surgery, acute vascular, and acute pediatric surgery should be a very, very integral component of the general surgical training once these people, they become general surgeons. So they should know what to do in emergency situations for these patients. And then I would actually, put up certain recommendations, which are certain recommendations which have already been placed and certain recommendations which need to be placed. So first of all, my recommendation for the health department, because it is the health department from where most of our trainees would be incorporated into our surgical training programs. The assessment of surgical units as a part of robust, regularly quality assessment of surgical training programs with the ability to enforce improvement or removal of accredited training posts as required. Every surgical unit does not have the right to become a training unit. There are certain fixed standards, and the health department should actually be looking into is that whether a surgical department is fulfilling a criteria to be accredited for a training position. A methodology for enhanced selection process for trainees entering surgical training should be developed with a definitive input for the trainer surgeons. At the moment, the health department is sending us trainees which are not with the recommendation from their trainers. So it's very important that that has to be incorporated. And the training course costs and the training fees should be borne by the training institution so as to reduce the burden of living on the trainees. The trainees should not be worried about that, who's going to pay their fee for the courses, who's going to pay their fee for the examinations. It has to come from the training institutions. And I must let you know that there are certain training institutions in the city and in Pakistan who actually bear all this cost as well. And an enhanced annual review of competence progression process for surgical training should be developed to support competence-based progression as to facilitate the termination of training where trainees are not meeting the appropriate standards. And this should include a robust criteria that should assess knowledge, skills, and professional behaviors to determine the ability of a trainee to progress. It is very important to understand that every person who comes into a surgical training program cannot become a very good surgeon. And, if they have to be stopped, if they're not up to the mark, then they have to be stopped early in their careers, and they should be given an alternate pathway for getting a post-graduation done. Because becoming a surgeon is not easy. It's very hard work, and it is actually a prolonged training, and it is difficult to get this training. So it is very important to understand that if the department thinks that this person is not fit to become a surgeon, then some alternate pathway should be available for that person to be incorporated into another training program. And where appropriate, the early years of surgical training should be broadened to accommodate training in the areas that are relevant to that specialty. Now, this means that I am thinking about and speaking about the enhancement of the training duration, because I don't think that we are providing competent, well-trained surgeons during this, short time period. And this is into the thought process of the Council of the College of Physician Surgeons as well. And then I've already put these recommendations for the College of Physician Surgeons in Pakistan. And number one is that the trainees should have a robust intermediate module exam with clinical stations appropriate to the postgraduate level of this exam. They have to be really very standardized, and the trainees should go through a very rigorous and robust intermediate module examination, and there should be no repetition of basic academic recalls already assessed in the FCPS 1 curricula. An effort should be taken to enforce workplace assessments on trainees so as to generate greater trainer and trainee engagement. The workplace-based assessments are a very integral component, and now the College of Physician Surgeons of Pakistan should make it mandatory. The training progression should be competence-based rather than time-based, and wherever necessary, the time duration of training may be enhanced. In each phase of training, there should be clear targets that determine whether the trainee is able to progress to the next phase or not. The targets will include knowledge, clinical skills, technical skills, and professional skills. So it is actually the joint responsibility of the College of the Physician Surgeons of Pakistan and the health departments of the concerned province that in each phase of training, there should be a clear target that would determine whether the trainee is able to progress to the next phase or not. So that we should be able to provide an alternate pathway to these trainees so that they can pursue their careers in some other kind of post-graduation. And the surgical curricula should be revised using a framework that includes the concept of entrustable professional activities. Simulation should be embedded and enhanced within the surgical curricula, and there should be sufficient resource to ensure availability for all the trainees. And I'm progressing towards this, that these simulation centers would be available in all regional centers of CPSP, inshallah, within a year's time. The certificate of completion of training holders should be competent in generality of the specialty and should be able to deal with at least 90% of the patients presenting in that specialty. And that is the kind of certification we would require from the supervisors, from the trainers, that they should certify that this trainee would be able to deal with at least 90% of the patients in emergency settings and in elective settings in that particular specialty. Now, that is the need of the hour, and that has to be implemented. And then few recommendations for the training of the teaching units. The surgical training units have to be dedicated, accredited, having identified trainers with appropriate funding and time allowed to fulfill their role in their teaching plan. The teaching units are different for service providing units. In the teaching unit, the focus is mostly on the training and teaching as well. Whereas at the moment, what we're doing is that most of the teaching and training units are taken as service providing units. There is no harm in that, but service provision should be a component of their training. It should not be the other way around. And mandatory teacher training for consultants supervising the trainees, it should be there. There should be increased regularity of the training days. There should be, dedicated 2 or 3 training days in a surgical unit with only training of the trainees is being done. And regional level access to advanced surgical simulation facilities, which should be offering availability out of hours coupled to simulation curricula for self-study in addition to supervised practice sessions. And that is what we are gearing up towards, that we will be able to build up advanced surgical simulation centers in different regional centers of CPSP, where out of the working hours, that they would be open in the late hours of the evening as well, so that they can come and practice over there. And there should be an improved regional career counseling services which should be offered to assist surgical trainees in successfully planning their careers and assisting and supporting those in difficulty for considering in changing of specialty. Sometimes during the progression of their careers, the surgical trainees, they find themselves that they're not fit for this specialty. Now, there should be some possibility of a career counseling either at the health department level or the teaching unit level or at the CPSP level, where these people who are having difficulty in their trainings, they should be counseled, and if they want to change their specialty, they should be helped out in this process, which we already do actually. And then there's certain recommendations for the training units. There should be formalized teaching clinics with reduced patient numbers and longer consultation time slots in order to allow appropriate supervision of active teaching of core and higher surgical trainees in the outpatients clinic setting. In our regular outdoors, there are hundreds of patients which are coming. So and we are actually, providing teaching simultaneously, not only to third-year students, fourth-year students, and final-year students, and then also to our postgraduates as well. But for the postgraduate surgical trainees, it is very important that they should have, teaching clinics, the OPD clinics, for which are dedicated for them, where there should be a limited number of patients, which they should be presenting these patients as short cases, and then trying to learn out from these short cases, and then making early decisions how to actually, decision making is an integral component of surgical training. So they should be taught how to actually, see a patient in a short time and make a quick assessment and then take decisions what to do for these patients. And they should be formalized, named weekly elective training list for core and higher surgical trainees. When I was a registrar, at least once a week, my professor would give me one operation table and give me few cases to operate under supervision and then independently, purely by myself. So that was being practiced many years back, few decades back, but now this practice has been stopped. The dedicated training elective lists are not there. I'm not saying that the whole list should be actually dedicated for that, but maybe at least where 4 or 5 operating tables are available, one operation table should be just reserved for the elective training list for the surgical trainees, whether they're core surgical trainees or higher surgical trainees, but they have to have a dedicated training list. and introduction and funding of local hospital-based skill labs with appropriate training and simulation equipment to allow the full implementation of a training curricula mapped to surgical training in a simulated environment. I was just gathering this data, and only 3 to 4% of the total hospitals in Pakistan have got dedicated surgical skills lab. So it's very important to have that. We really want to incorporate the learning process and the simulation-based learning. The skill labs are an integral component of that, and that is very important to understand. And developing surgical skills earlier through focused training opportunities, simulation, etc., so that time is not wasted, particularly in the early years of surgical training. The suturing skills, the tissue handling skills, and the laparoscopic skills, they should all be learned in the dry or wet labs. Because when they are coming into the live operation theaters on the operations of the humans, then very important time is lost how to actually teach them how to apply a knot, how to apply a laparoscopic knot, how to get a good laparoscopic skill. So that is not the place to learn. This learning has to be done in the dry or wet, surgical labs, which I have just remarked that they are very far and few in our country. So it has to be absolutely important and kept in mind that these skills labs have to be developed. And there's few recommendations for the trainees as well. What should be the trainees be doing? The trainees have an obligation to ensure that they make a proactive role in utilizing all the training opportunities available, including surgical simulation facilities. Because if surgical simulation facilities are not available in their training unit, then they should seek help from other training units through their professors, so that simulations should be learned. And I'm sure that all those people who have got simulation labs, they're very happy to allow people coming from other training units to allow them to come and work in the simulation labs. And trainees must be flexible to adapt on their own training needs and the training opportunities offered by each individual unit. Trainees should be well prepared, open to robust assessment, and open to feedback on the performance in order that training need can be adequately identified and introduced. Trainees have a professional obligation to their peers and trainees to provide constructive feedback on their experience of the local, regional, and national training structures, such that improvements can be made for future trainees. The trainees should be allowed to not only to work in that unit, but allowed to go and observe in the sister units, in units in different hospitals, and in units in different hospitals of the country, so that they develop a broader outlook, because this is going to help them in actually acquiring a lot of knowledge. And then what the trainers should be doing. The trainers should demonstrate their aptitude and qualifications to become educational supervisors through a program of mandatory training. That is what actually CPSP is doing at the moment. And trainers should be supported by an adequate amount of time within the job plan to ensure that regular weekly meetings occur with their trainees to manage, assess, and support their trainees. Now, I'm once again emphasizing on this point that a direct meeting with the trainer and the trainee is very important, at least for a short period of time, once a week, because that is going to sort out most of the issues. If you're not going to listen to our trainees, that what the trainees have to say about the training program, and maybe sometimes they come up with one of the most brilliant ideas which can be incorporated into a training program. So it is very important to actually give them and provide them time so that they can interact with the trainers. So the trainers should be having some time for the trainings every week. So if I sum up that, what should be the principal initiatives for improving surgical training? Number one is that provide the trainees with a better balance between training and service delivery. Service delivery is a component of your training, but the training should take a dominant role. Very little time should be given for service delivery, because this service delivery is a job of some other people who are non-medical professionals. They should be handling the service delivery. Improve the quality of training post by enhancing the role of trainers to enable them to dedicate more time to deliver training. So once again, it is the onus on the trainers to give a dedicated time to their trainees, so that they feel that the training is being imparted onto them. So encourage posts for trainees to work in one institution for at least 12 months to enhance relations with the educational supervisor. Adapt different rota designs to allow surgeons to train more during daytime hours. So, in one rota, the number of the trainees should be more, so that actually more time is given and dedicated towards training only. They develop surgical skills earlier through focused training opportunities, including simulation, promote a workforce from other professions with wider surgical team to support trainees to help deliver better patient care and free up their time for more training. And we should encourage competence-based progression and competency-based assessment, including the broad use of workplace-based assessment, because this is the tool. The workplace assessment would be the real tool to actually support and help our trainees to actually progress smoothly. And a refined process of selection, a proactive training, and an accomplished dedicated training with incorporation of modern technology in learning will result in a refined product, and this will really be the pathway to excellence. So I am very thankful to all of you for listening to me on my own thought process, and I hope that a part of this has already been achieved, but we really need to work very hard in achieving the rest of what actually has been pointed out in this discussion. And thank you very much for listening to me. Thank you.